Looking at your heart, you got some blockages in the arteries of the heart. You've got a valve that's leaky. You know, all the blood should move forward out of the heart into the body, and then that valve stops it from coming back into the heart. And that valve's not working so well. That blood's flushing back into the heart. That's worn down the squeeze of the heart, so your heart's not squeezing as well as it should be. And in addition to that, if that wasn't enough, you got an aneurysm. That aorta, the big artery in your body where all the blood comes out of the heart to get to the body, is enlarged, and it's pushing 5 centimeters. Normal is about 3. Okay. When it gets to, let's say that was the only problem you had. When it gets to 5.5 centimeters, that could cause you trouble, and bad trouble, dissection, or it can even rupture. And so we would replace it at 5.5 centimeters. When we're in there doing other stuff anyway, fixing these arteries in your heart and that valve, the cutoff is 4.5 centimeters, okay? Because give it 3 or 4 years and it's gonna be 5.5 centimeters and you're gonna be right back here having surgery again. So for us, the 3 things to fix are: 1, those blockages in your heart. So that would be what's called a coronary artery bypass surgery, okay? We basically take an artery from the chest wall, we take some vein from your leg, we go around those blockages, sort of like a detour off the freeway, getting around a wreck that's blocking it up, you get back on the freeway and get where you need to go. The valve, we take that old valve out and we sew a new valve in there, okay? In your age group, we would typically use tissue valves, okay? The only other choice is mechanical. With other things going on, there's almost no way I would put a mechanical in you. The tissue valves will wear out, but they last about 15 years. Usually when they need to be replaced, they can be replaced with a catheter. And then we need to fix the aorta at the same time to prevent that from causing you trouble down the line. Okay, so that's quite a bit of heart surgery. Okay, and it requires that prosthetic valve and a prosthetic graft that replaces that aorta. My concern right now is the bacteria swirling around your blood. If that graft gets infected, that is a big problem. That would be kind of a game over issue. Okay. What I want them to do is take a look with the colonoscopy, and I understand they're a little nervous, and there's nothing, that's risk-free, but I think that's a safer way to proceed, doing the colonoscopy first, knowing if we've got anything going on that needs to be addressed in the colon, because we do not want bacteria swirling around in there with that prosthetic material. Okay. When we do these surgeries, they're very safe these days, okay? But the risk is not zero, and especially doing the bypass and the graft and the valve, your risk, there's really no way to calculate it like you can for others. Your closest approximation would probably be about a 6% mortality risk, okay? So it's 6, yep. That gives you a 94% chance of doing fantastic. It's not small on the grand scheme of surgeries, but it's much lower than the risk of not fixing all these things, okay? Anytime we do cut the skin, there's a risk of bleeding, there's a risk of infection. Infection we talked about, we're gonna try to eliminate any extra sources of infection. We get that colon cleared away, risk of infection is less than 1%, okay? Risk of bleeding, less than 1%. Both of those can require we go back in and fix or clean out whatever's infected or bleeding. When we do the surgery, we put you on a machine to circulate your blood. There's a risk of damage to the lungs and to the kidneys. Those are both around 3%, okay? Most of that 3% are transient things that resolve by the time you go home from the hospital. There's a small risk of needing dialysis for the kidneys, exceedingly unlikely if possible. For the breathing, small risk of being on a ventilator for a longer period of time, or needing a special breathing tube, exceedingly unlikely if possible. There's around a 1% risk of stroke, okay, and there's around a 4% risk of needing a permanent pacemaker afterwards. So that's a whole lot of things listed out.
He needs a drink.
Yeah,
he wants something stronger than the water.
Probably makes it sounds like you're doomed, okay? But again, that puts you in the mid 90% chance of going through this with no problem whatsoever. And that number is far and away better than not fixing the aneurysm, not fixing the coronaries for certainly. And the aortic valve is going to slowly wear your heart down more and cause all those things anyway: kidney problems, lung problems, etc.
Let me ask you this: the colonoscopy of the lower vital fibers and more, and said that it's after the word John after GI and doing anything else besides a colonoscopy. Before it was do everything and wait 30 days for the other infectious disease doctor until the infection's gone and stay on the antibiotics. If it turns out there is colon cancer, depending upon it, or where it's spread or whatever, that's gonna delay, obviously, the heart issue.
Yeah,
Correct
well,
me if I'm inaccurate with what I'm saying.
I think that it's unlikely. We got a CT scan that doesn't show any, frank signs of spread through the abdomen or anything. Okay.
Okay.
If they got a colonoscopy, and sometimes they can resect these via the colonoscopy, and that would be sort of a low stress, low risk thing to do. If it's bigger and it would require abdominal surgery, then you would need to get the heart fixed first, okay? But we would know we need to keep you on antibiotics, and this is the surgery
Always.
we're gonna do on X date. Meaning there's no chance of this getting, I saw my surgeon, he wants to wait a little bit longer because of the sternum healing and all that kind of stuff, and then the antibiotics don't get refilled, and then a month later you're here with an infected valve and graft, and then 96% is gonna look super duper optimistic.
So go ahead and get the colonoscopy first, find out where we are there, and then we go from there.
Correct.
Is
Yep.
that what you're saying, Dan?
Yep. Alright.
And that would take place next week, I gather.
Well, yeah, probably right now. You we'll call the GI doctor
Yeah.
and see. It's possible it could be done tomorrow. I don't know, actually know what their kind of scheduling is, but I think more likely early next week, yeah.
So I still am on, I don't know how long that's supposed to be on the
Yeah, we'll be on
The,
there.
the antibiotics you're gonna be on until we sort all this out.
Okay. So that may be, end of next week.
No,
Hey,
go ahead.
no.
Come
That's
back.
So the plan is, one, get that colonoscopy and see what we're dealing with. Regardless of what we find, we can have a plan in mind and we can get dates
Okay.
and all get on the same page, and nothing's gonna get missed or lost,
Now,
okay? The heart surgery is probably gonna be towards the end of next week, okay? It's a long wait now, but it's just. we're sort of-
So I have to watch daytime TV?
I think that's.
That's in the cards?
But if that's the worst thing, then.
You say that the survival rate, certainly it should be around 94%, correct me if I'm inaccurate.
That's correct.
Well, I never expected that, I figured it was best 50-50, but,
Oh, no.
the reason I bring it up, I had an uncle who, had a similar scenario 20 years ago.
Yeah.
And, his surgeon, close friend, and, told him it was 90% that he wouldn't make it. And, but if he didn't do it, he wouldn't have any wind left, and he'd have to be in a wheelchair, and would probably live 3 to 5 years. And, he said, go ahead and do it, or I'm not going that way, so. I'm pleasantly surprised that it's 94% today.
Well, that man was 80
And it
years
may
old
be
at the
you.
time, too.
That's the
And it may
advantage.
be you.
Well, it's a little bit of you and a little bit of me. It's, you're not in an emergency situation, which ups the risk quite considerably. And your squeeze, although it's not great, is not as bad as we've seen. If you needed all this done and your squeeze was, when people started having heart failure sort of symptoms and they're down in the 15-20% range, then you're talking, good chance of not making it through something.
And rehab in this situation is a couple of months, is that?
Well, full recovery from this surgery is about 2 months, so it's not necessarily rehab. You look like if you're up and getting around pretty good, I would plan on at least a week in the hospital, okay? And this also sort of depends on what we find in terms of colonoscopy. I would plan on a week in the hospital, and then about 6 weeks total of feeling sore, tired, trouble sleeping at night, tired during the day, trouble eating, stuff like that in terms of poor appetite. and that usually lasts around 6 weeks to 2 months. But you can be at home for that. You know, the caveat is there's no heavy lifting. So this bone we go through the sternum in the middle of the chest. If you put weight on your arms, it puts weight on the sternum there. So he asks you not do any heavy lifting, pushing or pulling more than 5 pounds for 6 weeks while that sternum heals. 5 pounds is about a gallon of milk. So no taking out the trash, doing grocery bags or laundry baskets or mowing the lawn or anything like that for 6 weeks.
Wow.
That
Yes,
seems
who
like-
gets those jobs?
Oh,
that part got a smile. So there's some upside.
no, I don't mind working.
It's his turn. I had 5 broken ribs. So
Oh,
he
boy.
did all of my chores as well as his, which is probably worse than the other way around anyway.
So what do I do next?
All right, now it's hurry up and wait. So we'll get a hold of the GI doctors and get the colonoscopy underway. Once we have that, I'll take a look at the OR schedule. I'm afraid that this might be till Friday, but I'm going to see if there's an opening before that.
Before Friday for what?
For the heart surgery.
Of next week?
Correct.
Or something.
Okay.
Jim Smith, has he been in touch with you at all?
No, I assume you were seeing.
So Dr. Salmon is talking with Dr. Smith about you.
Good friends.
Yeah,
That's,
yeah.
Jim Smith,
Yeah, I'll speak with him.
okay.
All right.
All righty, I'm trying to think of anything else. You pretty much, took all the, you can go home and eat and take a rest, because I know you've probably had a long, tough day.
So who did your cath at St. Joe's? Was it Solomon? So you got
Yeah.
transferred to
Yes,
Solomon.
Dr.
Yeah.
Okay, good. Okay. I'll speak with them as well.
That was amazing, you know, for somebody who's never been in the hospital.
Lay there awake and watching
No,
pictures of your heart.
two both, yeah, and,
Yeah,
technology's come a long way.
that has. Prepare me
I hear
to rest.
nothing but good things about you, and, so, just want you to know that out there. Outside of your short term.
Good. We do a good job here. We do a lot of sort of complex surgeries right away. So
You get plenty of rest on Thursday nights?
I'll have to check and make sure I'm not on call Thursday, but I'll
That's his party night,
Make
honey.
sure you're rested up, because
I'll be rested.
I haven't had much rest in the last couple of weeks, and, any sleep, so.
So we'll take good care.
I'll need to get it.
Absolutely. But we'll take good care of you. Once we see that colonoscopy, we'll come back and we'll talk about the findings.
And that's probably gonna be Friday or Saturday or Monday or.
So I just talked to Dr. Bhatia, he said Dr. Prasad will most likely do it on Saturday. Because you have to do a prep, so you probably have to do
Right.
prep tomorrow, and then the
Prep
colonoscopy
is
on
what,
Saturday.
I can see it's 20.
You don't get
They
to
change
eat,
it all
which,
the time, so I'm not sure what it is. You poop a lot.
Well, I haven't eaten much, so
Yeah.
hopefully it'll be a lot of that.
Yeah.
Well,
Yeah.
you'd be
I've had
surprised.
one
You'd be surprised.
I've had one before. The
How
prep,
long- how long
prep
did it
moves.
last?
See, he's had a colonoscopy.
You'd be amazed
He did
at
great.
what could be in there.
License
No
plates and
trinkets in
everything.
there. No trinkets. Volume of fluid.
Yeah.
All right.
Okay.
Any questions for me? I know that was a whole lot of information all at once, but the bottom line is.
No,
we
I
got-
Yeah,
appreciate it.
nowadays I wish I'd gone
Once.
to school for a different degree and it would have included stenography, I think.
Right, yeah.
Okay, well, we'll be back, obviously several times before we get this done, so if you have any questions, just write them down.
Okay.
We'll get them answered.
Okay.
And I'm sorry, I've forgotten what your name was already.
It's Mellor, M-E-L-L-O-R.
Okay, thank you.
More.
You see, we also have 2 grown daughters who are heavily involved, but out of the area. So, well, they come into the area.
Okay, well, I'll be here tomorrow too, and we can go through it as well.
Yeah, now I think there's enough here. My son-in-law is a vet. So although I realize their people and pets are
Yeah,
different to a
he's,
degree, he understands
he
all of
would
these
like
kind of
to-
things. And
He
so,
would like to be the one, cheering right before I go pass out.
That's not nice. Well, we won't let him in then, okay?
We'll be back, but certainly if you have any questions, do write them down and then we'll get them all.
I certainly will. Thank you so very, very much.
Very nice to meet you.
Appreciate
Nice to meet you
it.
as
Bye.
well.
Good to
Have
see you
a
guys
good
again.
Bye-bye, nice seeing you.
And do me a favor, if I make you mad, tick you off at all, let me know ahead of time.
Yeah.
That's the one you gotta watch out.
Thank you.
Thank you ever so much. He's my kind of guy.
That is not the one that we had originally thought.
That's Malone Bloom.